Hi, and welcome to Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan Pelter.
I'm Stacy Tsai.
And welcome back.
Today we have Dr. Michael Gibson, who's going to be talking to us about cardiogenic shock. So Dr. Gibson is an associate professor of medicine and an assistant director of mechanical circulatory support at University of California, Davis. Dr. Gibson received his medical degree from Einstein College of Medicine in New York. He completed his internal medicine residency, his cardiology fellowship, and his subspecialty training in advanced heart failure and transplant at University of California, San Diego. Dr. Gibson is board certified in the American Board of Internal Medicine, advanced heart failure and heart transplant, cardiovascular disease, and the National Board of Echocardiography. So let's go ahead and take a listen to Dr. Gibson's talk.
My name is Dr. Michael Gibson, and I am an associate professor of medicine, as well as the assistant director of mechanical circulatory support at the University of California, Davis. Today, I'm going to be talking to you about the basics of cardiogenic shock. I'll be teaching how to identify cardiogenic shock, as well as the management of patients in shock. And I'll be discussing the use of PA catheters, inotropes, and of mechanical circulatory support. So first, just to start with a case, this is a 63-year-old man with a past medical history of diabetes, hypertension, and hyperlipidemia, presenting with severe chest pain over the last 4 hours. He has a blood pressure of 85/40 and a pulse of 95. His oxygen status is 98%. And as you can see here in the CCG, he already has these very large ST elevations anteriorly, as well as ST depressions and reciprocal changes in the inferior leads. As you would expect, he has an occluded LAD, which you can see here. I'll move my mouse actually. And the LAD was actually revascularized with PCI, but despite this, his systolic pressures remained in the 80s. He had an LVEDP of 28. A right heart cath was performed. He had a right atrial pressure of 12, a PA pressure of 48/27, a wedge of 29, and had a cardiac index of 1.7 liters per minute per meter squared by thermal dilution. So just talking about the definition of cardiogenic shock, and this actually comes from the SHOCK 1 trial. This is the inadequate end organ perfusion due to reduced cardiac output despite adequate circulatory volume. So they have a cardiac index less than 1.8 or less than 2.2 while on inotropic or pressor support, and they're overloaded. They have a wedge greater than 15 or an LVEDP greater than 18. And of course, the shock part having a systolic blood pressure less than 90 for at least 30 minutes, or requiring inotropic or pressor support to keep them above 90. Now, in the previous case, it was fairly simple to define the patient in shock. You had them coming in with an acute event. You had a right heart cath as well as an LVEDP that fits these criteria, but not all cases are that simple and straightforward. In terms of what you'll be seeing in patients with cardiogenic shock, about a third of the cases are going to be acute myocardial infarction. They'll be going to the cath lab, possibly getting a stent, possibly needing bypass. A third of the patients will have a chronic cardiomyopathy, and then a third will have a mixed bag of different causes, whether it be severe mitral regurgitation, an RV infarct, myocarditis, Takotsubo, or aortic regurgitation. But cardiogenic shock complicates about 5 to 10% of acute MI cases. That's 40 to 50,000 patients per year in the United States. And the subsequent ventricular dysfunction is the most frequent cause of cardiogenic shock in these MI patients. Less frequently causes of cardiogenic shock is the mechanical complications, whether it be VSD, free wall rupture, and acute MR. So of course, as you go to see these patients that are coming in with a STEMI or acute MI, if you hear a new murmur, definitely do a bedside echo before going to the cath lab. So long as you have time, figure out what is going on with that. You wouldn't want to miss a new VSD as the patient may have come in late. We've been seeing quite a bit more of that during the time of COVID. Here's the next case, a 35-year-old male with a history of non-ischemic cardiomyopathy, and he has a non-adherence to medications, mainly because he has difficulty in getting the medications. Multiple admissions for heart failure, who's being admitted at least once a month, and is admitted to the floor to medicine. You're seeing the patient as a consult, and currently he has not really been making much urine. He was placed on Bumix 2 milligrams IV. He typically takes 4 milligrams at a time at home. His home blood pressure is a systolic in the 80s to 90s to begin with, and currently he's 85 over 40, so not too far off from where he usually is. He has no edema on his legs, and because of this, he was restarted on his home Carvedal of 12.5 milligrams twice a day, as well as Entresto. When you go to see him, you'll note that his JVP is elevated up to his ear, and that he does have cold or cool lower extremities. And so this is the type of case that it becomes much more difficult to say whether or not the patient is truly in cardiogenic shock. So you look at the signs and symptoms. You don't really have the right heart cath to back you up with numbers at this point, but should the patient have an altered mental status, have that cool, clammy skin, particularly when feeling the kneecap at the back of your hand, having an elevated JVP, an S3, having oliguria, increased serum lactate, or an end organ dysfunction, this would kind of point you in the direction that this person may be in cardiogenic shock or heading that direction. So every time I discuss an elevated JVP with any trainee, they always say, I'm not really good at that, estimating the JVP, it's difficult to see. And really, it's something you want to practice on patients immediately before or after they get a right heart cath. If you send them to the cath lab before you do one bedside, really try to estimate what the right atrial pressure is going to be and see how closely it aligns with what you have on cath. Likewise, if you have a patient with an increasing creatinine as you continue to diurese them and they're clearly overloaded, it may be possible that they need some inotropic support. If it is unclear about what is going on, why the creatinine continues to rise despite diuresis, then it may be necessary for you to go to right heart cath to figure out what exactly their volume status is. As these patients come in, one of the things that you really want to do is try to get a sense of what their risk of mortality is going to be. And there's a number of scores that you can look at. This is the card shock risk score. There's also the intra-aortic balloon pump risk score, which is more recent. But really it gives you a better idea of just how this person is going to do within this hospital, in-hospital stay. The other staging system that you really have to know for patients in cardiogenic shock is the SCAI cardiogenic shock stage, which is relatively recent. The staging system is A through E, A patients being those at risk, such as a patient with an MI or a history of heart failure. These patients are neither hypotensive nor tachycardic, but let's say you end up giving them a dose of beta blocker when they're so volume overloaded, that may actually push them into cardiogenic shock. So they are at risk. Stage B is the beginning of cardiogenic shock. So you have hypotension and tachycardia, but without hypoperfusion. Stage C is what we think of as the classic cardiogenic shock. And this requires some intervention, whether it be inotropes, mechanical circulatory support, that there's hypotension or tachycardia with hypoperfusion, but the patient is not deteriorating on these interventions. And stage D, deteriorating, so failure to respond to any initial therapies, hypoperfusion with deterioration, but not yet at the point that you consider refractory. Stage E, extremis, this is the refractory cardiogenic shock that we are very concerned about and really try to do everything we can to get these patients back. The differing degrees of shock severity also will have a varying responsiveness to interventions and different clinical outcomes. So of course, the stage E extremis patients are going to have a much worse clinical outcome than the patients with classic cardiogenic shock. And you wouldn't necessarily think to start just inotropes if a patient is already in stage E coming in the door. There's definitions that I've included for what you would be considered hypotensive, hypoperfused, deteriorating, or refractory. Essentially, it's similar to what we were talking about with the definition of cardiogenic shock, hypoperfusion having an admission lactate greater than 2, urine output less than 720, or creatinine that is just continuing to go up during the first 24 hours. Deterioration, meaning that you need to have an increase in the number of vasoactive medications within the first 24 hours. And in terms of refractory shock, meaning that despite everything that you're doing, you're increasing the vasoactive medications during the first hour, more than 2, needing to do an intra-aortic balloon pump, still having shock. One of the ways that you're going to be able to differentiate these patients and help manage these patients is by putting in a PA catheter. And I know from the ESCAPE trial, not everyone uses PA catheters, but there is more data out there that suggests that this is really helpful for those patients that are in cardiogenic shock. The one caveat to that being that you have to get a complete assessment. So meaning that you have to have the PA systolic and diastolic pressure, the wedge pressure, as well as the CVP to be able to measure that right atrial pressure. And this is just looking at the data. So patients overall, if you get a complete assessment of the pressures, as well as the PA sat, those patients tended to have a better mortality whether they're even overall stage D or stage E patients. And really what you want to do is you want to do this up front. You don't want the patient to be sitting around in cardiogenic shock in the ICU and just be flying blind. You want to have this at a time where you can figure the patient out, much like there's a hemodynamic profile in heart failure. We have those same profiles in shock, where you have primarily LV shock, so LV congestion. You can have primarily RV congestion, or you can have biventricular shock. So, and this is based upon the pressures, based upon the wedge versus the CVP or right atrial pressure. And this is going to help you be able to know what you need to do in terms of inotropes, or if you need to put in mechanical circulatory support. You don't want the person getting worse overnight. So as soon as this person comes into the ICU, it's best to actually place this either at the bedside or send the person down to the cath lab, but don't wait until the next morning. So the 2013 ACC/AHA heart failure guidelines recommends the use of invasive monitoring to guide therapy in patients with respiratory distress or impaired perfusion in whom the adequacy or excess of intracardiac filling pressures cannot be determined from clinical assessment. So even though you're able to do an assessment of the right atrial pressure, you may not have a clear idea about what the wedge is. You may want to be able to compare those two. And this is in a time when we have temporary mechanical circulatory support being much more common. This is going to be able to help you choose that device or devices much better to match the patient's needs. It also allows for early identification of those who have significant compromise requiring MCS. So you have a patient on inotropes, you keep going up on those, and you're able to see that despite that, the PA sat is still remaining low. You haven't been able to unload the LV. You have to go to something else. It also provides early recognition of the biventricular state, which is often underappreciated, which in that you may have to go to doing BiVAD or consider for ECMO. The use of PA catheters also allows you to know in real time just what is the patient's volume status. It allows you to adjust vasoactive medications in a targeted fashion and be able to monitor the responses to those therapies. And it also allows you to see when the patients can be weaned from these devices. Again, don't fly blind, get the PA catheter in early as possible and know what therapies the patient needs. Just to touch on inotropes and pressors, I could probably give a full 60-minute lecture on inotropes and pressors itself. Well, you do want to know each of the inotropes and pressors you're going to be using, the benefits and major side effects of each of them. Everyone has their own preferences in terms of inotropes and pressors. Most commonly, dopamine, dobutamine, norepi, as well as milrinone and vasopressin, as well as epi, which I don't have here on this list, are the most common to be used in cardiology. Phenylephrine, a little less common, although useful in those patients with aortic stenosis and hypotension, as well as on the HOCM patient to reduce that LVOT gradient. The one thing I'll note is that as the number of inotropes continue to increase, your risk of mortality does go up. So if you find yourself putting patients on a pressor and an inotrope, or two pressors or two inotropes at a time, you may want to start considering mechanical support at that point. So just a few key points about pressors and one point about afterload reduction. So if you see the patient heading into shock, you have maybe the systolic blood pressures in the 90s, maybe a little bit on the cool side. You may have a very elevated systemic vascular resistance. Afterload reduction is something that obviously is going to be helpful. So using captopril or hydralazine, if the patient is in the ICU, using nitroprusside. So in these cases, a lot of times you'll actually see the blood pressure come up. The person may warm up and they may actually start diuresing a little more quickly. But for those patients with a very low cardiac index, using dobutamine or milrinone may be necessary. So a couple of things to know is the onset of action for dobutamine is much shorter than it is for milrinone. So you're going to see the effect of dobutamine much quicker. Milrinone may cause a little more hypotension than dobutamine, and typically I find that dobutamine will cause the person to have a little more tachycardia. Dobutamine is a lot less effective than milrinone when the patient has been recently given a beta blocker, and then tachyphylaxis to dobutamine also exists. So some patients may require being switched over to milrinone. In terms of for pressor support, so norepinephrine at this point remains the first-line agent. It has been compared to dopamine as well as epinephrine in previous studies. And for those that are severely hypotensive, the systolics as low as the 70s, and or having a low SVR, norepi is the first one most people will go to. So the other thing to keep in mind is that pressors and inotropes are more effective in combination. So using levofed in combination with milrinone may help in terms of the inotropic support, as well as not to increase your afterload too much from the epi or norepi. Moving on to the mechanical devices. So these are the 4 devices that we'll be talking about today: the intra-aortic balloon pump, the Impella, tandem heart, as well as the VA ECMO. So the intra-aortic balloon pump and the Impella, intracorporeal, and the tandem heart and the VA ECMO, extracorporeal. The indications for these devices, primarily for high-risk PCI, when a patient has LV dysfunction, or if it's multivessel stenting or left main disease with LV dysfunction, high-risk VT ablation for those in cardiogenic shock, stage C to E, and for cardiac arrest requiring ECMO-assisted CPR for return of circulation. The primary goals of non-durable mechanical circulatory support are to increase vital organ perfusion, augment coronary perfusion, reduce ventricular volume and filling pressures, and mechanical power expenditure, thereby reducing wall stress and myocardial oxygen demand. So the first we'll discuss is the intra-aortic balloon pump. This is probably the one that you are most familiar with. It's probably the most commonly used. So it will reduce both peak LV systolic and diastolic pressures. You can see it sitting in the aorta. And as the heart is contracting, the balloon deflates, thereby dropping the afterload. As the heart relaxes, the balloon will inflate and can assist with coronary perfusion. It's to also increase the LV stroke volume. It does not increase your cardiac output that significantly. What we're talking about is about half a liter a minute of cardiac output, 1 liter at most. The balloon pump benefits patients that have an acute MI, that receive lytics, post-infarct angina, mitral regurgitation, or ventricular tachycardia. And it primarily may help those that may be in stage B shock and are awaiting either a transplant or an LVAD, and some patients in C. But we don't really know exactly which patients within the classic cardiogenic shock it is helpful for. So when you are on ICU, on your ICU team, what you'll want to be looking for is that the balloon is inflating appropriately and augmenting your diastolic pressure. So this is an unassisted systole. You have your dicrotic notch here. Again, unassisted systole, and then you have your balloon inflation right at the right time, right at the dicrotic notch. So you'll have your augmented diastolic pressure. So your diastolic pressure will actually be higher than your systolic pressure. And then as the heart begins to go into systole, the balloon will deflate, dropping your end diastolic pressures, and will drop the afterload so that the heart has a much easier time contracting. So this is your assisted systole. The assisted systole has maybe lower than your unassisted systole. There are some issues in terms of timing with a balloon pump. So these are probably the worst that can happen. So if you have late deflation, that's probably the worst. So as the balloon is inflated, it doesn't deflate at the right time. It actually deflates late, and you have the heart contracting against an inflated balloon. It's going to actually increase your myocardial oxygen demand and actually may increase your LVDP, and the balloon may actually be hurting your patient. Likewise, if you have early inflation, so the heart is contracting, and then even before it is able to fully empty, the balloon inflates, increasing your afterload, increasing your myocardial oxygen demand, and not really being able to fully eject. Late inflation and early deflation are less dangerous, but you're not really using the balloon to its full potential. So you're not really inflating right on the dicrotic notch, so you have less diastolic augmentation. And again, if you deflate too early, you're going to have your end diastolic pressure begin to rise before you have your assisted systole. While you're on the ICU, you're going to want to get a chest X-ray every day that you'll have the intra-aortic balloon pump and check its position. You don't want it to go too high and cut off low to typically the left arm, or be too low and really occlude those renal and splanchnic arteries. Same with the PA catheter. You want to check its position, make sure it's not way out into the periphery as you inflate the balloon. So here you can actually see that's the tip of the balloon pump. You want it to be just below the aortic knob. The other site that you can look at is the carina. If you look at the carina and find the balloon pump is approximately there, that's a good site for it to be. The next device we'll be talking about is the Impella. So this is one that you may also be familiar with. It's an axial flow device, continuous flowing percutaneous LVAD. So it sits within the LV. It has an inflow and an outflow. So it sucks blood in and basically sprays it back out into the aorta. It reduces the native heart contractility. So basically giving the heart a break. And there's many different types of Impella. So the 2.5 typically would be used more for high-risk PCI or high-risk VT ablation. Typically for shock, that's not going to be enough benefit. We would usually go for a CP, which gives us about 4 liters per minute of cardiac output, or the surgical devices, the 5.0, or now the 5.5 Impella. The RP device is for those patients in right-sided failure who need right-sided support. So whether it be an RV infarct, or if you have someone who needs biventricular support, you may be using a CP plus an RP in those patients. So contraindications would be if the patient has a mural thrombus in the left ventricle, if they have the presence of a mechanical aortic valve, you can't pass the Impella through there, you're going to be having a lot of issues with that, as well as AI. If you have aortic valve stenosis with an aortic valve area less than 0.6 centimeters squared, so has it been done? It has, but it's you better have the pump up and running by the time you get it across that valve, and the patient's not going to be doing very well. Moderate to severe aortic insufficiency, severe peripheral arterial disease, and if they have a VSD. They have a VSD, it's going to be sucking blood from the right, and the patient may become cyanotic. Complications of this device. So one, hemolysis is probably the most common, and this is due to the mechanical shearing of red blood cells. You can also get thrombocytopenia for the same reason. Many times it will respond to repositioning, but also you want to make sure that you have a CVP in the range of about 10 to 12 so that the RV is able to supply enough volume over to the left side. At times you may have to back off on the speed of the Impella to keep the RV, allow the RV to be able to keep up. Persistent hemolysis may also result in an AKI. Bleeding, of course, is one thing we get concerned about, and these patients will be on heparin. Limb ischemia, as this is a large cannula that you'll be placing in the leg, and then also stroke. So when you look at the screen, this is what you're going to be seeing. And what you'll see here, this is the placement signal. So this should look like an aortic waveform, which it is here. You'll also be looking at the motor current, and it should actually have this up and down appearance. So as the heart is beating, as long as there's some pulsatility there, the motor current should actually be picking up. You also have your Impella flow in terms of liters per minute. So this is when the Impella is positioned incorrectly. So one case I've had previously was a case of a patient who had the Impella at a particular length, let's say 87 centimeters at the leg. The device was alarming that the Impella was not placed in the correct position. There may be some slack, or the device may be pulled back or moved forward during this, even though it remained at the correct position at the leg. The full Impella was actually in the LV and was not affected. So the LV EDP was remaining high and the patient did not do well. But here you can see this is an LV waveform, and you have a flat motor current. So this is poorly positioned. You have to do a bedside echo at this time, and would want to reposition it. So you'd have to actually pull it back so that the outflow is in the aortic groove. This is probably a worse situation in which you have the inflow and outflow both on the same side. You have a flat motor current, and you have a waveform of it being the aortic waveform. So this tells you that the Impella is completely out of the ventricle, and you may be able to get it back in, pushing it in under echo guidance. But primarily what you would want to do so that you don't damage the aortic valve is to get the cath lab back in and be able to get it back in place if necessary. The newer devices have what's called a Smart Assist. So you're able to see both LV and aortic waveforms. And if these two match, then obviously it's going to be fully positioned. You have the Impella flow in the same place, and you have the cardiac output. So this includes not only the Impella flow, but also the native cardiac output. And this calculation here, the cardiac power output, which helps us be able to decide when we need to go down on the device performance level. So on this device, you don't get to set what the flow is, you set a performance level, which correlates to a particular speed in revolutions per minute. So you may start at a P9 or P8 level and try to unload the LV as much as possible. As the patient does well, you're able to take down the performance level. And as you do that on a daily basis, you'll want to get an echo and make sure that the LV is actually improving, or that you're not, that the LV or RV are not becoming distended. Once you get you don't want to take it anything below P2. If you take it below P2, you can start to have more AI than what you're actually bringing out of the LV. And at that level, you usually look to take it out. The measurements you want to look at, so conventional hemodynamics on your PA catheter, you want to check at least a daily lactate. Cardiac power output, as I was mentioning, should the patient have a cardiac power output less than 0.6, you may want to consider increasing your support, but potentially increasing the size of the Impella to a surgical Impella, 5055, or adding ECMO support. Also consider calculating a PAPI, so PA systolic minus the PA diastolic pressure over the right atrial pressure. And if it's less than 1, that's severe. In that case, you would need more RV support. As I had said, you want to do a bedside echo daily. This doesn't necessarily have to be done by the sonographer, but what you're really wanting to check is the cardiac function and the VAD positioning. You want to have multi-specialty rounds at a minimum communicated on a daily basis to make sure all teams are involved and know that what is going on with the Impella and as well as the patient in total. So this is what you're going to see on your bedside echo. So this nice figure here will show that this is perfectly in place. You have the Impella catheter. This is the inlet here, and you want to measure up to the aortic annulus, and that should be about 4 centimeters. You don't have to get too obsessive compulsive about this. If it's 3.5 to 4 or 4.1, that's okay. So you're going to usually measure to this ball-looking thing here where the train tracks end up to the aortic annulus. You want to make sure that it's not overriding the mitral apparatus, the mitral valve here, the anterior mitral leaflet, and making sure that that is opening up well, and that it's not too deep or too far back. So here's our next case. We have a 52-year-old female who had a lap chole, which was complicated by an injury to the common bile duct and had subsequently had sepsis. The patient had become acutely tachycardic to the 160s and was hypoxic, had pulmonary edema on her chest X-ray. So an ECG was done. She did have anterior ST elevations in this case, and a bedside echo was done. In this particular bedside echo, given the case, as well as what the echo looks like, you'd be thinking Takotsubo. The person continued to deteriorate, having systolic blood pressures in the 80s, worsening pulmonary edema. And we ended up placing an Impella on this patient. And you can see she does have some degree of coronary disease there in the LAD as well, which was intervened on. If this video actually starts, there we go. So that was intervened on as well. And this is just looking at 2 views. So the peristernal long axis view, as well as a 3-chamber view. And you can see here that the Impella actually looks like it's being a little bit far out and needs to be pushed back into the ventricle. By day 5 of being on the Impella, we saw full LV recovery as she came out of that Takotsubo, and she did very well. So the next device I want to talk to you about is the tandem heart. This is a device that's less commonly used at my current institution and actually in previous institutions, but this is a device that's extracorporeal. So here is the pump. It's a centrifugal pump rather than an axial flow pump, which would be the Impella. So the cannula goes up the IVC into the heart and crosses the atrial septum to draw blood off the left atrium, bringing it down into the pump, and is reinserted into the common femoral or iliac. So it's basically unloading the LV by unloading volume. It's a 21 French cannula crossing the left atrium. And so the interventionalist has to be particularly good and confident about doing a transseptal puncture. And there's the cannula crossing the septum there. So this is on a particular case that we had. Here you have the device, the cannula crossing the intraatrial septum. We had a PA catheter in place. This person had a chronic cardiomyopathy. And here you can see the venous cannula with fully oxygenated blood as it was being taken from the left atrium and then being reinserted into the common femoral as it passes through the pump. This is the pump interface. So on this device, rather than picking a performance level, you get to choose the particular speed in RPM. Again, you don't dictate the flow. A lot of times this is dependent on not only the RPMs, but what the right ventricle is able to supply to the left side, as well as a number of other factors. So this was the patient that you saw previously, that she was a 50-year-old female that had a chronic cardiomyopathy. She had worsening pulmonary edema, shortness of breath, worsening renal dysfunction. Despite inotropic support, we ended up putting the tandem heart. And this was only a few hours after placing the tandem heart device. You see that her pulmonary edema had actually improved. At this point, she was headed towards needing dialysis, but her renal function rapidly recovered. She was actually able to go on to get a durable LVAD in the same admission. And I'll tell you later, she actually ended up being bridged to a heart transplant. So the last device we'll be talking about is the extracorporeal membrane oxygenation, or ECMO. So this consists of a pump, an oxygenator, and here's the controller here. There's many different types, so this is just one that you may work with in your time. So there's a few ways that you can cannulate. You can directly cannulate into the heart. That's done surgically. If it's done at the bedside, or if your interventionalist is doing the cannulation, it's probably going to be through the femorals. So the femoral vein is cannulated with a 21 to 25 French catheter right up towards the right atrium. So drawing blood out of the right atrium, bringing it down out of the venous system, oxygenated it, passing it through a pump, or through the pump, then oxygenating, and bringing it back through the common femoral or iliac. And the femoral artery cannula is a 17 to 21 French inserted to the taper with the tip at the common iliac artery or lower aorta. So with these patients also, because this is a large cannula, you want to have an antegrade perfusion cannula inserted. So this can be just like a 5 French cannula to have antegrade flow so that you don't lose flow to the rest of the leg, and that'll prevent distal limb ischemia. So once again, this is the peripheral cannulation. So as you cannulate into the leg, blood doesn't just move forward and supply blood flow to that leg. Nature absorbs a vacuum, and so the blood will actually go backwards. And how far up it goes is dependent upon what your LV function is, as well as what speed you're running your ECMO at. So if there's respiratory insufficiency, if your lungs aren't working very well and they're sending deoxygenated blood over to the LV, that LV is going to be sending deoxygenated blood back out of the system. And the first place they're going to go to, of course, is your coronary arteries. The second place they'll go to is the right arm. So it's very important that you'll have a radial or brachial art line on the right hand so that you're able to measure those sats and accurately know what the sat is that's being supplied to your coronaries and potentially even the cerebral vessels. So there's advantages and disadvantages to ECMO. One, it's relatively inexpensive once you have the devices compared to Impella or tandem heart, but it is something that does require a lot of support, either by having nurses be trained to do the perfusionist job, so very labor intensive. This can be done in a minimally invasive manner through peripheral cannulation. This can be done even during a code. As I said, bedside deployment. I've seen this done in multiple areas of the hospital, whether it be the ED, cath lab, or bedside. And this supplies biventricular support, as well as the oxygenation supplies pulmonary support. As I said, it is labor intensive. You'll have to do ACT monitoring. You can monitor anti-10As as well. A lot of management issues that you'll have to keep track of in a high complication rate. and the patient, in a lot of these cases, is mobilized. Now, some centers have moved to be able to walk the patient, though I find this to be a little less common. And of course, as you're sending blood back towards the heart, this increases your afterload, as you see here. So we're going from the orange curve to the blue. So you'll have an increase in afterload on the heart, and that may cause worsening LV distension on a heart that's already not doing well. What you want to avoid in these patients is having a bridge to nowhere. So once the device goes in, you already have to start thinking about, how am I going to get myself out? How am I going to get this patient onto the next thing? Are they going to recover? Are they going to need a VAD? Or are they going to need a transplant? So a patient that does not have a recoverable heart and is not a candidate for transplant or VAD should not be going on to ECMO in the first place. If they have severe chronic organ failure, that would be another absolute contraindication. Severe brain injury or prolonged CPR, if you're looking to put in the device after the patient's been coding for more than an hour, they're probably going to have a poor outcome as it is. Severe peripheral vascular disease and severe aortic insufficiency. So relative complications being if they're obese, if they have a malignancy, contraindication to anticoagulation, any patient with advanced age, although this is relative as well, you can have someone who is a very good 75-year-old and some patients that are not as good 60-year-old. And then of course, compliance. If this is a person that could otherwise get a VAD, but there are financial issues or cognitive issues or social limitations that is going to prevent them, that has to be taken into consideration. Although again, this is a relative contraindication. So this is one patient that we had that's a 31-year-old female with primary pulmonary hypertension, and she presented in shock. You can see her RV is well overtaking her LV here. Again, her LV is just getting squashed by this huge RV that's been under a lot of pressure for a long time. Let's see if I can get this. So ECMO actually ended up being placed to support the patient as well as provide oxygenation. And you can see just the RV becomes unloaded. That RV is much smaller than what it had been. Well, you see that the LV also becomes somewhat enlarged compared to previous. Again, here, it's not quite as big as the RV, but that is due to that increase in afterload on the LV. And this is prior to ECMO placement. So you see the pretty clear lung fields, and this is immediately after. So you have lots of pulmonary edema, which ended up worsening. The patient needed an LV vent due to this dilated LV in order to unload it and to assist in getting rid of this pulmonary edema. This is one case of a 49-year-old female with a bicuspid aortic valve and severe aortic stenosis. She received an AVR and actually was doing rather well. She was actually working with PT when she was found to have complete heart block postoperatively after pacing wires had already been removed. While she was working with PT, she had collapsed. She was receiving CPR when emergent ECMO was placed at the bedside. Intra-aortic balloon pump was placed as an LV vent. But as the patient is in complete heart block, it was not enough to allow the patient to actually recover. The intra-aortic balloon pump was not enough of an LV vent. And as you can see here, this is a TEE looking at the left atrium here. It's just completely full of thrombus. And I'll tell you, the LV was full of thrombus as well as the pulmonary veins, the pulmonary artery, and there was thrombus even within the RV. So having an adequate LV vent prevents thrombus within the LV. Obviously, this patient was not able to go for transplant. There could have been other choices made to actually make this patient have a more sufficient LV vent. Of interest may be that this patient had come to my service while in asystole. This is while she's on ECMO and has balloon pump. So the balloon pump is supplying all the pulsatility as the patient has, the ECMO is a continuous flow device. And she's setting 99%, not breathing at all. So this is the last case. This is not for any device in particular, but just to discuss one case of cardiogenic shock and just to show how complex these patients really are. So this is a 25-year-old male with tuberous sclerosis and a mitral valve prolapse with severe MR, who was actually presenting with diarrhea and a fever to 38.6. Blood pressure was initially okay at 90/50, but he was having heart failure and had a sodium of 126 to begin with. creatinine 1.55. He had a previously normal creatinine of 1, and Staph aureus bacteremia was actually discovered in his blood. You can see here the degree of MR that he has is severe, and he does have a significant vegetation there on the valve. On day 3, he had a hypoxic respiratory failure, had acute dysarthria, left lower extremity weakness. A CT of the brain was found to have a right MCA CVA, as well as a left basal ganglia hemorrhagic focus, which was both thought due to embolic phenomena coming from the endocarditis. He was transferred to the cardiology service, and a right heart cath was placed as the patient had worsening pulmonary edema as well. So initial right heart cath has an RA pressure of 12, RV 50/12, PA was 50/21 with a mean of 34, wedge of 26 with V waves, all the way up to 36. This is due to the severe MR. And a thick cardiac output of 5.52 and an index of 2.77. So not terrible, but the hemodynamics suggest that he is volume overloaded. PA sat was 53%. So due to the hemodynamics and the severity of the mitral regurgitation, an intra-aortic balloon pump was placed with a plan to get the patient to a mitral valve replacement. He had increased work of breathing, was placed on BiPAP, and they had initially tried to diurese him. He was very tachycardic with heart rates up into the 120s at this time. Unfortunately, an esmolol drip was actually started on this patient. The patient had an EF of 50% in the setting of severe MR, so you can be assured that the EF is not truly 50%, it's probably much worse than that. And nitroprusside was also started for afterload reduction. The reason why I'm saying unfortunate about the esmolol drip is it's going to reduce his cardiac output further and could actually worsen his current state and worsen his pulmonary edema. So after these initial measures, despite the balloon pump, right atrial pressure remained 15, PA pressure 50/28, wedge 30, cardiac output 5.5, and index of 2.7. So not much has changed despite the nitroprusside, despite the intra-aortic balloon pump. He continues to do worse and actually is taken for the mitral valve more emergently, though he has difficulty in coming off of bypass. ECMO is, the patient is cannulated for ECMO in the OR, and an LV vent, a direct vent in through the LV apex is placed. So just to go back, where you can see the new mitral valve, blood is actually flowing through the LV, actually exiting through the aortic valve as well as through the LV vent. Unfortunately, this patient was able to come off of ECMO. So ECMO was weaned, and this was done with the support of the Impella. So the patient did not require biventricular support. We had him on only LV support following this. And it's good to make that step down from the larger, more complex device onto one that is supporting just the LV. And you can see just how bad his LV function truly is following that mitral valve replacement. So his EF in this case was about 15%. In this case, you can see the Impella is overriding the mitral apparatus. There was concern in actually changing its placement in this case, as it concerned that it may actually pop back. So it was actually left alone. Flows were okay in this particular case. So in this, it's a judgment call. And the patient actually did have the Impella weaned off and actually did very well. It was discharged from the hospital. So the key points of shock is that you want to recognize it early and have rapid team mobilization with an agreement implant. So you want to be at the patient's bedside, be able to feel that they are cold and clammy, know that their altered mental status or their oliguria is due to cardiogenic shock, recognize that they are fluid overloaded, talk to your attending early, look to get a PA catheter, and look to see what you need to do. In patients requiring MCS, every hour that you delay an escalation of therapy increases the risk of death about 10%. So the hemodynamic monitoring is crucial to management and to your decision making. So you want to make sure that you get that in, as I mentioned, the night that the patient comes in or when you find them in shock. So right heart cath associated with 39% absolute increase in survival during hospitalization. You want to assess for potential escalation or weaning of devices based upon multiple measures. And mortality increases exponentially with the number of inotropes used. So 26% survival when 4 inotropes used don't let it get to that point. Look to get a mechanical circulatory support or look for another plan. Make sure that you communicate between teams at least on a daily basis. And I'll tell you that on these patients, these are very complex patients, as you saw with the last case. You really can't just be rounding on these patients just one time a day as a fellow. You really need to know everything about them. You have rapid changes throughout the day, and you want to be able to make those changes yourself and see what happens. So on these particular patients, I would be at the patient's bedside 3-4 times a day at minimum, seeing what needs to be done, seeing that the patient is making a recovery, and if not, making the changes necessary, talking to the teams to make sure that changes are made. So they are, as I said, rapidly change and have increasing complexity. This may occur in a matter of hours. So be on top of these patients. And thank you very much, and I'll take any questions.
That's perfect. Well, we want to thank Dr. Gibson for giving us such a good talk on cardiogenic shock. It's a really complex topic, as you guys can see. And I think mechanical circulatory support it's intimidating because it's new, particularly for new first-year fellows. So we will be collecting questions from you on Dr. Gibson's talk. So please email Megan and I. You can reach us at our scripts email. Megan's is Pelter, PELTER.Megan, MEGAN @scripshealth.org. And you can reach me at TSAI.Stacy, STACY @scripshealth.org. And then we will do a live Q&A with Dr. Gibson on Wednesday, August 18th. So please do send your questions in prior to that. We'll be recording that live Q&A and we'll have it up where Dr. Gibson answers all of your questions. And of course, the following week, we have Dr. John Evans from Stanford, and he's going to be talking about tachycardias and bradycardias. So definitely look out for that talk. And thank you for joining us.